Feeding is much more than just eating. It is one of the very first and most complex tasks a baby must learn. This process is a beautiful dance of development. It involves the body, the senses, and the bond between a baby and their caregiver. For an occupational therapist, understanding this dance is essential. We help individuals participate in the meaningful activities of daily life. Feeding is one of the most fundamental of these activities. It lays the groundwork for health, growth, and future skills. Observing and supporting feeding allows us to see how a baby's entire system is working together. Our role as occupational therapists is to look at the whole child. We see how motor skills, sensory processing, and the environment all connect during a meal. Is the baby able to hold their head up? How do they react to the feeling of milk in their mouth? As a student, you are building your foundation of knowledge. Learning about feeding skills is like learning the alphabet before you learn to read. You will learn to observe the subtle movements of the tongue, lips, and jaw. You will see how a baby's posture affects their ability to swallow safely. This detailed understanding will become your most powerful tool. It will guide your clinical reasoning and help you create effective interventions. This video will guide you through the stages of infant feeding. Use this knowledge to build confidence and sharpen your observation skills. This is where your work to support function and participation truly begins. A newborn baby enters the world equipped with powerful primitive reflexes. These reflexes are not learned, they are automatic responses that ensure survival. When it comes to feeding, the most important are the rooting and sucking reflexes. If you gently stroke a newborn's cheek, you will see their head turn toward the touch. They will open their mouth, ready to find the source of food. This rooting reflex helps the baby locate the nipple for feeding. A beautiful, instinctual behavior that initiates the connection. Once the nipple touches the roof of their mouth, the sucking reflex is triggered. This creates a suckle, swallow, breathe pattern. The tongue moves forward and backward, creating negative pressure to draw milk from breast or bottle. This early suckling helps the baby organize their sensory system and calm themselves. The anatomy of a newborn is perfectly designed for this early feeding stage. Sucking pads in the cheeks provide lateral stability. The tongue is relatively large for the oral cavity. The jaw is small and slightly retracted. This setup makes suckling efficient and helps protect the airway. The larynx is positioned higher in the neck, adding protection against aspiration. These features work in harmony to make early feeding safe. As an OT student, your observations at this stage are critical. Watch for the presence and strength of these reflexes. Observe the rhythm and coordination. Can the baby take several sucks before pausing? Note signs of fatigue or stress, like falling asleep quickly or changes in skin color. These early observations provide the first clues about oral motor and neurological well-being. Understanding these foundational reflexes prepares you for more complex assessments. This knowledge forms the basis for recognizing developmental progression. As a baby grows beyond the first weeks, their feeding patterns begin to mature. The initial reflexive sucking gives way to a more voluntary and controlled process. This transition, typically around 2 to 4 months, marks a significant milestone. The baby is no longer just reacting, they are actively participating. Their oral motor skills are becoming more refined with a more defined suck pattern. This true suck involves up and down tongue movement, creating a stronger seal, leading to more efficient milk expression and better coordination. The suck-swallow-breathe pattern becomes more robust and flexible. A newborn manages a simple one suck, one swallow, one breath pattern. An older infant can string together long bursts, 10, 20, 30 sucks before pausing. Sustained sucking bursts indicate good control and neurological maturation. Physical changes support this skill as sucking pads reduce and facial muscles strengthen. The oral cavity enlarges, giving the tongue more room. Better head and neck control provides crucial postural stability. A stable head position provides a secure base for oral motor work. For the observing OT student, this phase is rich with information. Check the quality of the lip seal. Is it strong and complete or leaking? Listen to swallowing sounds. Are they clear and crisp or wet and gurgly? Observe overall body language. Are they calm and engaged or showing stress? Watch for stress cues, arching their back, splaying fingers, turning head away. These cues communicate the baby's feeding experience and guide our support. Understanding these signals helps us adapt our approach for success. These observation skills form the foundation of your clinical expertise. Systematic observation leads to accurate assessment and effective, family-centered intervention. Between 4 and 6 months marks a monumental shift to purees and spoon feeding. Readiness isn't just age, it's a collection of developmental milestones. One key sign, the disappearance of the tongue thrust reflex. When it disappears, babies can accept a spoon and move food back to swallow. They also need good head and trunk control, able to sit with support. Postural stability is non-negotiable for safe spoon feeding and airway protection. You'll notice keen interest in food, watching you eat with focus, opening their mouth when food approaches, or leaning forward to ask for a bite. First spoon experiences are a new sensory and motor challenge. Babies must learn to open their mouth for the spoon, then use the upper lip to clear food off the spoon. At first, puree will be pushed out by the suckling tongue, and that's normal. Over time, they learn a new tongue movement to move food back for swallowing. This transition takes practice, patience, and messy meal times. As an OT student, observe and support the parent through this process. Notice how the baby responds. Do they willingly open their mouth or clamp shut? Watch tongue movements. Is the thrust reflex still strong, or are they managing the bolus? Watch reactions to new tastes and textures. Do they grimace and spit, or show curiosity? Guide parents on spoon choice. A relatively flat spoon is often easiest. And on pacing the meal, letting the baby set the speed for comfort. Maintain positive, encouraging interactions throughout the learning process. Your role is to educate parents about gradual introduction and realistic expectations. Remember that this is a developmental process requiring time and practice. With support and patience, babies develop competent spoon-feeding skills that build toward independence. The next chapter unfolds between 7 and 12 months. This stage is all about refinement and introduction of complex skills, munching, biting, and drinking from a cup. The early vertical munching pattern is the precursor to mature chewing. When a soft solid is placed on the gums, the baby responds with up and down movement. This is not yet true rotary chew, but the foundational pattern for breaking down solids. It strengthens jaw muscles and teaches the brain new ways to process food. As munching becomes coordinated, the baby develops more controlled biting. They learn to use their gums, and later their emerging teeth, to bite off pieces of soft foods. This requires significant motor planning. Opening just wide enough, closing with just enough force. The tongue develops more sophisticated movements, moving side to side. This tongue lateralization is crucial for moving food from center to molar area for chewing. Around the same time, these coordinated movements develop together. Parallel to chewing developments, the baby is ready to learn cup drinking. This is very different from sucking on a bottle or breast. The baby must take a small sip, manage it in their mouth, and coordinate swallowing. Initially messy, with wide jaw excursion and suckling tongue patterns. Your observational focus expands during this phase of development. When observing chewing, note if it's simple up and down or developing diagonal and circular movements. Watch the tongue. Does it effectively move food to the side or stay centered? For cup drinking, observe jaw stability and flow control. The journey of learning to eat is not just motor skills, it's a profound sensory experience. From the moment a baby transitions to solids, their sensory systems are flooded with new information. Every new food introduces different tastes, textures, temperatures, colors, and smells. Sweet, sour, savory, bitter, silky smooth purees, lumpy mashes, soft solids, crunchy foods, chewy foods. Temperature, color, and smell are all sensory inputs the baby must process and integrate. For some infants, sensory exploration is joyous and easy. They're curious and open. For others, new sensory properties can be overwhelming. A baby with sensitive oral sensory system might gag on lumpy texture, not from choking but because the sensation is too intense. They might refuse foods of certain temperatures or colors. Communications about sensory thresholds. These are not picky eating behaviors. They tell us the input is too much, too soon. Sensory acceptance develops gradually and requires repeated positive exposures. A baby might need a new food offered 10 to 15 times before attempting to taste it. This process should not be forced. The goal is low-pressure, playful environment. Allowing a baby to touch, smear, and play with food is vital sensory learning. Food play desensitizes the tactile system and helps the brain become familiar with food properties. It builds a foundation of trust with eating before food enters the mouth. As an OT student, observing sensory responses is key to understanding each child's profile. Suggest bridging. Mix tiny amounts of new food with well-liked foods. Building acceptance without distress through patient, systematic exposure. While many infants navigate feeding development with ease, some encounter hurdles along the way. These difficulties arise from various causes, and it's the OT's job to be a detective. Some challenges are motor-based, like a baby with low muscle tone. They may lack the postural stability needed to sit upright for feeding, or have weak oral muscles leading to poor suck or difficulty chewing. Their endurance may be low, causing them to fatigue quickly during meals. Other difficulties stem from structural issues or medical complexities. A baby with tongue tie may have restricted movement, making latching difficult. Infants with GERD may associate eating with pain, leading to feed refusal. Children with cardiac or respiratory conditions may lack endurance for the demanding suck-swallow-breathe pattern. These medical factors must be considered as part of comprehensive feeding assessment. Sensory processing differences are another major source of feeding challenges. Some infants are hypersensitive, over-responsive to sensory input. For them, lumpy food texture, broccoli smell, or spoon feeling can be intensely aversive. Conversely, some children are hyposensitive, under-responsive to sensory input. They may not feel food properly, leading to overstuffing or pocketing food. Significant safety risks. Feeding difficulties rarely exist in isolation, they impact the entire family dynamic. Parents may feel worried, frustrated, or guilty when their child isn't eating well. This stress can be felt by the baby, creating negative feedback loops. As an OT, support the dyad by providing reassurance and education. Offer practical strategies that reduce pressure and rebuild positive feeding interactions. Work collaboratively to transform stressful mealtimes into positive experiences. Understanding feeding difficulties requires considering motor, sensory, medical, and family factors. Your holistic approach addresses the whole child and family system. As an OT student, your most important tools are your eyes, ears, and hands. When assessing infant feeding, begin before the food even appears. Check positioning, hips, knees, and ankles at 90-degree angles when possible. Ensure the environment is calm and free from distractions like television. During observation, use a systematic approach to assess all components. Look at oral structures, facial symmetry, lip tone, cheek tone. Watch oral motor skills, lip seal, tongue movement, jaw excursion. Listen for feeding sounds, rhythmic suck, clear swallow, or signs of trouble like coughing. Note the baby's communication, leaning in for more, pushing away, arching, or crying. Always document what you see and hear in objective, descriptive terms. Based on your assessment, begin to formulate supportive strategies. If a baby has weak lip seal, provide gentle cheek support to help maintain closure. For textured food struggles, recommend foods that dissolve quickly, like baby puffs. For overwhelmed babies, advise dipping spoon tip in puree for tiny tastes. Always work in partnership with caregivers. They are the experts on their child. Provide them with knowledge and tools to make mealtimes more successful and less stressful. Teach them to read cues, hunger, fullness, and distress signals. Model paced bottle feeding. Tip bottle down periodically for baby-controlled flow. Empower parents with sustainable, impactful interventions as coach and collaborator. The path from newborn's first suckle to toddler's competent chewing is remarkable. Your holistic perspective enables you to see beyond just the mouth to consider the whole child. You are preparing to nurture not just competent eaters, but healthy individuals, with lifelong positive relationships with food, supported by your compassionate, evidence-based practice.